Pure Urology viewers, urologists. Today is a special day for Pure Urology. As you all know, we have started the Pure Urology during Corona time, thinking that I was also free and many of the DNB students or MCA students will try to learn some surgical techniques as well as surgical technique related issues. Uh, since then, we are continuing this, and today is the fifth year completed. Kindly continue the same encouragement for us, all the viewers as well as the speakers. And I am fortunate that Dr. Sabnis sir, at that time I requested, not so planned, but I requested sir that we will start with you, sir, because he teaches well the PCNL and all endourology procedures. So we started, and it became a habit that every year anniversary day I'm requesting Dr. Sabnis sir to do the program. This is again fifth anniversary. There is nothing like anniversary here, but we feel honestly that something could be continued with a lot of enthusiasm. Wish I will continue as long as the audience are there, because a lot of urologists are coming, 300, 400 urologists are coming. For them, URSL is again new thing. For them, PCNL is again new thing. So with that introduction, I will share a small video out of happiness that how we did this. And after that, I will read this Sabnis sir's CV. Though many of us Indians know, but for the juniors, I will read, and then I will continue the program. So this is a video of representing 5 years of Thank you very much. And today's topic is common mistakes done with the while doing PCNL. The intention is that the PCNL training, PCNL number of cases, number of the institutions who are training the people have significantly increased, though cases might have decreased. So the one urologist during the 3 years, even though he learns, chances of he doing mistake because of the lack of maximum experience will be there. They will go to the tier 2, 3 cities, tier 3 cities. There is a chance you may struck and nobody is ready to help, or there are situations where you might end up in trouble. So if you know those mistakes through these lectures, probably you may avoid is the intention. So to speak about that, Dr. Sabnis sir, definitely Dr. Sabnis sir has encouraged me in the 2007 to 2010 when I post MCH from Urology PGI Chandigarh. I used to go to Nadiad. He used to encourage like any other student, and over a period of time, he attended our state conferences, South Zone conferences, and like he has a habit of encouraging the juniors talent to pick up and then make them again a faculty. So the place where I have learned RIRS in Nadiad, the same place I have operated along with Dr. Oliver Traxer. That is the capacity of the some teachers. I am thankful for that. I'm proudly introducing sir today. He is the chairman, Department of Urology, MPUH Nadiad, Gujarat. He has over 38 years of teaching experience in urology. He currently serves as regional director, World Endourology Society, West Asia. He is also a member Education Committee of the World Endourology Society. He leads the Store and Endourology Committee of SIU. He is the Deputy Director at UAA, Urology Association of Asia. He is the past president of the Urological Society of India. He has authored 4 books, 23 book chapters, and 160 peer-reviewed publications. He has delivered over 350 national and international presentations. He is a recipient of multiple PCS awards, including the USA President Gold Medal, Honorary FRCS from Glasgow. He is also a recipient of the SIU Distinguished Career Award and Ralph Kaeman Mentor Award, World Endourology Society. So it's a every line is very important. Not to waste time, let us go for the discussion about the cases which may trouble and with which we can avoid the complication. Thank you, Sabnis sir. Over to you, sir.
Thank you very much. And let me just share my presentation.
Yes, sir.
And
Yes, sir. Screen
okay.
is viewed.
Thank you. Thank you very much for, first of all, asking me to be the part of this pure urology group. And as you rightly said, that it started in 2021 when all of us actually were delivering and doing presentations on Zoom. And that time, along with you also, there are many people who started some groups, various activities and this. But most of those groups, activities, forums, platforms, they died down, the enthusiasm went away, and eventually everything was forgotten. I must give credit to you that you persisted in this activity, and not only persisted, but flourished over a period of last 4, 5 years. And therefore, from the small activity of pure urology with very little intention of imparting the knowledge, now it has become one of the biggest group on the Facebook of consisting of more than 12,200 urologists, which is not a simple thing at all, and which involves the across the world various people who have joined this group, and the activities that you are continuing, that activities that you are conducting on a very regular basis is really commendable. I must give salute to your enthusiasm and your the experience and skill and potential to make sure that not only the activity is to be started, but it has to be continued on. And therefore, right from day one to this fifth anniversary, I'm very happy to be associated with this pure urology group.
Thank
Today,
you.
I'm going to talk about the common mistakes done in PCNL. As we know that PCNL is, if you see that way, it's a simple thing. But if you see that way, it is a very difficult thing. If you see the PCNL invention, which was in 1980s, so it's almost now more than 30, 40 years of PCNL invention. And in spite of spending 30, 40 years of PCNL, still people have to discuss about the how to make puncture, what are the problems, what are the mistakes, which itself indicates that it is a surgery which has potential hazards, it has potential problems, and those problems can be sometimes very hazardous, and they can cause a tremendous amount of morbidity and occasional mortality also. And therefore, it is very important for us to understand as to what are the mistakes that are likely to be done when you are performing PCNL. Many times the mistakes are magnified because there is nobody around you, there is nobody to help you. And therefore, I'm going to talk about the common mistakes. I'm not going to talk on a very rare mistakes of the ectopic kidney, pelvic ectopic kidney, and then the mistakes done in that. But a common mistakes which are encountered by the urologist who is in tier 2, tier 3 city. That is what Dr. Chandramohan's intention was. Very simple things. There are many things which mistakes which we do, which actually we don't even understand that this was a mistake unless and until the problems and the complications occur, then we realize, oh, I should not have done that. It was my mistake. So I'm going to highlight all those mistakes today and compile them for the benefit of the viewers of Pure Urology. Well, we have been told right from beginning, from our school days, that you have to learn from your own mistakes. You learn from your own experience. Once you do too many surgeries, once you do too many things, then you learn from your own experience. And once you do your mistake, you understand why you made that mistake, and you learn from every mistake that you make. And therefore, the person who learns from his own mistake or learns from his own experience is called as wise man. All of us, we try to be wise, and we were told that you have to be wise man because you have to learn from this. But the era is changing. It is not enough to be wise. Now we are in the smart era. Everything is smart. We have smartphone, we have smart mobile, we have smart everything. And therefore, to be wise is not enough. You have to be smart. And who is the smart? Is the smart person is the one who learns from others' mistake. He doesn't have to do mistakes. He has to learn from the others' mistakes. And who is the smart person who learns from the others' experience? So you have to not necessarily commit all those blunders and mistakes, but you learn from the others who have done that mistake and you don't repeat those mistakes. That's a smart person. And therefore, today's lecture, I'm going to talk about the common mistakes done during PCNL. So you learn from what mistakes we have done, what problems we have faced, what complications we have encountered, and how we overcome that. That is what I'm going to highlight today. My focus of the talk will be the common and the simple mistakes. There are some aspects in PCNL which we really don't give importance unless and until we realize, Arey, this was the problem which I did not give importance. So I'm going to highlight all those things which we don't give importance. There are many aspects in PCNL which we assume. There are certain investigations, there are certain protocols, there are certain things which I assume. Unless there is something goes wrong, we realize, that this assumption actually was not correct. And that was a mistake. So I'm going to highlight all those things. So mainly this talk will be for those who have started their own practice recently. So relatively junior people and those in tier 2, tier 3 cities, which they have to face lots of things and they can learn from all these mistakes. First and foremost, when you are starting new practice or when you are in the peripheral cities, in the beginning of your practice, you must select the simple cases. Now, over a period of residency, and if you have worked after residency somewhere, obviously you know what is simple case and how to select the cases. You are not going to select the complete stagon with the compact callaceous stones and the narrow infundibuli and undilated system. Obviously, it's a complicated case. But a case, straightforward case, 3 centimeter stone, renal pelvis, dilated system, these are all simple cases. So simple cases in the beginning will give you a lot of confidence rather than collecting and doing the extremely ambitious PCNL right in the beginning practice is a mistake. Don't do that mistake because something will go wrong. If it goes, everything goes fine, it is okay. But if something goes wrong, it will shatter your confidence and it will give a little setback. In the beginning of your practice, you don't want that thing to happen. You want everything to be to get you a confidence and therefore select simple case. Do the way you have practiced. Just because somebody is promoting supine and you have practiced all along prone, or somebody is, you just attended a lecture and said, oh, prone has a lot of benefits, but you have learned in supine way. So don't change it. Whatever you have practiced, the whichever way of dilatation, whichever way of this, which you have practiced over a period of your residency and subsequently later, continue to do that. In PCNL, let me tell you, after 30, 40 years of my experience, there are hundreds of ways of doing PCNL, making a puncture, making dilatation, doing nephroscopy, breaking the stone. There are several ways. There is no one single way which is correct and one single way which is not correct. Everything is correct provided your ultimate outcome is correct. So the way you have practiced, the way you have achieved success, continue to do that. Approach should be as you are comfortable. Just because somebody is promoting supine PCNL does not mean that you change your approach to that. If somebody is promoting a particular way of doing puncture, all along you have practiced the bullseye puncture, and somebody is promoting and somebody is explaining you, no, that other method is good, doesn't mean that you have to change. So approach should be whatever you are comfortable, whatever you have learned should be changing again and again is a big mistake in PCNL. So approach should be and your methodology should be such that whatever you have practiced, whatever success you have obtained, you keep on doing same thing repeatedly again and again and again and again so that you become master of it. Rather than 10 cases by this method, 10 cases by that method, again another case by other method, then you will not be confident, you will not be acquiring the skill. Also, there are many mistakes which are done in investigation. My advice to everyone is never compromise on mistake, which we quite often we do it, especially when patient is financially little compromised. We tend to cut short on the investigation, and and 7 or 8 out of it you will get away with it, but sometime you will end up in a problem in such a way that it will shatter your confidence. It will give lots of complications, and your reputation will be at stake. So unnecessarily don't compromise on investigation. Ultrasound, X-ray, QB, NC, there are many investigations which are there, and you select whatever investigation you think is appropriate, go ahead and do it. Just because patient is not affording or just because something is not there, doesn't mean that, okay, now I have seen many patients refer to us, they have made some complications and then they came to us, and when we ask the history, when we see all the previous investigation, they said no, X-ray was not, no CT scan was done. On ultrasonography they diagnosed stone, and then they was taken up for PCNL, and they landed up with the complication. Now that's not right, that's not even the teaching, that's not even a guideline. So don't unnecessarily compromise. You will, moment you compromise on anything, you are bound to head the complication. So if possible, do get the CT scan CD, see the frame by frame. Again, just don't go by one picture which they may come with, that it is the picture which is created. It is a CT scan is showing few frames and few pictures, which is not appropriate. See all the plates frame by frame. If required, get CD of the CT scan and see for yourself what is anterior, what is posterior, and then plan it out your PCNL. Especially if it is an abnormal kidney, if it is a previously operated kidney, it's a distorted calcium, distorted thing. So you must have every idea. Remember, investigations are done to give you the understanding as to what you are likely to face during surgery. And therefore, your mistakes will be much less if you are well aware that, okay, this is what you are going to face. In our residency, we used to do laparoscopy, we used to do laparotomy, and that was a very common operation. What was a common operation in emergency? Exploratory laparotomy, because there was no investigation. You explore, open and see what it is, and then close. Half of the time it was open, close. You thought that is something, and you open, it is not there. Then you remove the appendix and then close it. That's not right. Now we are in a modern era. You have to have every idea. There should not be last minute surprises on table. That is not correct. And therefore, do every possible investigation which is required. Don't make a cut short in the investigation. Now, let me give you just simple example. This is what is the simple stone on ultrasound. Is a good, nice, thick kidney, and probably the pelvic or the lower calyceal stone. Now you have only one frame. Now, guidelines show that NCCT. NCCT showed 11.4 mm stone, and now obviously you think that, oh, this is a very simple case. You want to do mini PCNL as a hard stone, and I want to do mini PCNL. You take up for mini PCNL. And now if you see what is the picture, if you the CT IVP, the picture is completely different. The stone is not in the pelvis, it is not into the proper infundibulum, it is outpouching, it is a completely separate calyx, which you did not get any idea on the plain CT or in the X-ray KUB. And therefore, all these things are important that you have all the investigations available. Now you know that what problems you are going to face. You can plan accordingly, and then your success rate will be much, much higher. Many times urine culture is not done because patient has come today. He had history of fever for 2 days, 3 days, and now he is relatively okay. Now patient has come prepared. I want to go ahead and do surgery. He is willing for surgery. Now you go ahead and do surgery. Now urine culture is not done. Don't avoid it. If it is possible, do it properly. Sometimes infective stones can be relatively asymptomatic, but we have seen that doing culture, making sure that you give culture specific antibiotics, make sure that active infection is not there. And if you do surgery, your success rate is far, far better. Common mistake is that because patient is demanding, patient is hurrying up, you say, okay, I will go ahead and do it. And then you do surgery. And then at the end, you find that you are landed up with the severe sepsis. We have burned our fingers, we have burned our thing, and we have done that mistake. And therefore, it is important that you learn from the other's mistake. And therefore, make sure that the patient doesn't have active infection. If he has active infection, no harm in waiting. Explain to them properly. Patients will understand that what is the problem, what are the hazards, provided you explain to them properly. Also, make sure to take proper history, whether patient is on clopidogrel, aspirin. Quite often, patients don't understand the value of telling everything. They may be taking anticoagulant and they may not tell you. So it is your duty specifically to ask for it. Also, it is a good idea to do the proper coagulation profile, especially if there is any history, especially if there is some bleeding, previous bleeding episodes. Quite often we have seen that even in spite of any positive history, there are some patients who have coagulation abnormality, and then they can land up with the problem if you don't detect it properly. So my advice is that don't do that mistake of the compromising the investigations and making this whole thing cut short. Again, instrument. Invest in the instruments, at least mini perk, conventional nephroscopes. There are many options which are there. There are digital options which are coming up. You can reduce the cost by combining Indian and foreign make instrument, but don't say that, okay, I have only conventional nephroscope and therefore whatever case comes in, I will do only with conventional. Or I have only one mini PCNL. So whatever, even if it is a stagon, I will keep on doing mini PCNL only with that. Then you will have problem. So don't compromise unnecessarily on this thing. That is a common mistake which is done. Other thing about the selecting Siam. Now, this is very important in practice that make sure that there is no lag. Quite often we have seen, and when we go to many places for the live surgery demonstration and is that, we see that there is a lot of lag. If you have a lag in the Siam, your puncture will not be, you will be little diffident in approaching your puncture because in Siam, what is important is that it should give you a real time image. So there should not be any lag. If there is a lag, you will not realize that this is a real time image. So this thing has to be checked when you are buying Siam, when you are selecting Siam, that has to be checked properly. Again, facility for image store is very important. When you see the last image, that image should be stored. There are many SIAMs which do not have this facility, and therefore, moment you put the SIAM off, the monitor becomes blank, which is not right. You must have that X-ray image memory available. check the radiation status, because you are going to do PCNL for many, many years. So radiation hazards are very important. There are many urologists, radiologists who have landed up with the problem, and this cannot be taken lightly. It's a common mistake to understand that, Array, no, no, this is all right, yeah, this is costing double money. Why should I take it? Don't compromise on radiation, your own hazard. Proper lead apron is absolutely necessary. Clarity has to be there. The brightness contrast in the CM should be there. Recording facility should be there. So learn to keep a foot control. Quite often your radiation will reduce to more less than half once you have control with you, rather than depending on person there who is going to show you this, because he will not know that when to press and when to put it off. Your foot control will definitely have a far, far better control. So your own health is important. So make sure that don't compromise on that. Endo camera. Common mistake is to compromise on the endo camera. Select a lightweight, proper endo camera. You don't need a very heavy endo camera and HD and a 3 chip and this that. Endo urology, you don't need too much. You need a very lightweight camera which will give you proper vision. No need of very hi-fi system. That is all needed in the laparoscopy. But in endourology, PCNL, RIRS or PCNL, URS, TURP, you don't need. Make sure that colors are natural and the clarity is far, far better. Next, I will spend little time on mistakes which are done in sterilization. PCNL does not mean that it is a mistake only in the technical aspect. PCNL is the surgery which involves pre-op preparation, sterilization, your pre-operation protocol, your post-operation protocol, and part of the mistakes are done during surgery. And therefore, why I'm stressing this is that it is a holistic approach. It is not that I have mastered the technique and therefore I will not make any mistake in my technique. But if you make mistakes in all these things, your technique has no value. Even if you are master in the technique, you will still end up with problem. Use the best possible technique in your own place. Sidex, paraphase, parasafe, as per the norms should be used, not just dip the scopes into the Sidex and within 2 minutes you take it out. That's not acceptable. Don't compromise immersion time. Wherever possible, autoclave. Now, most instruments are autoclavable, and therefore, autoclave is the best and the cheapest method. As far as possible, use autoclaving for surgery, which will give you a complete sterilization, not just disinfection. After surgery, clean your own instrument. Now, very important when you are having your own practice in tier 2, tier 3 city, that you can't just rely on the nurses. Okay, they will take care of it. Your wear and tear will go away. You will, whatever you have earned, actually will lose because of the nurse's mistake. So clean your own instrument, your infection will go down and your maintenance of instrument will be far, far better. So follow all the guidelines for sterilization. What we do is that this is what we tell our own residents. This is what we tell, that how to take care of the instrument, how to make sure that it is sterile. Just because you have autoclave does not mean that everything is fine. All these small, small channels, even though you have ETO, even though you have plasma sterilization and everything available, does not mean that everything will become all right unless and until it is properly cleaned. So after every case, the cleaning has to be done. All the small instrument, forceps and this that. So blood clots remain, all these joints, the blood clots remain. There is nothing like sterile blood clot. Just because blood clot is on, I am going to plasma sterilize it or I am going to autoclave it. So it is all right that whatever blood clot, even if it is there, it will become sterile. That's a wrong concept, completely wrong. So all this blood has to be washed out, clots have to be removed with the brush, with the all the thing. Then what is important is that all these small channels, see, our instruments have gone down in size. Now we have mini perk, we have MIP XS, channel size is just 3 French, 2 French. Now how to clean it? Unless and until you have a force irrigation pressure. Now this is a pressure pump. See, all the channels are kept to be kept open and force. They are very simple. This is not costly at all. It is available with any mechanic. but it is extremely useful that it will clean up all these small channels from inside, and it will make sure that the infection rate will go down. Understand? Now, this is a pressure pump, which is for the dry air. Now, you will get this any mechanic. It's very important that after sterilization, before you send it to autoclaving, or before if you are ETO, sending for ETO, or even the plasma sterilization, you must dry it properly. Now, this is how you dry it. Make sure that this is a blower. This will go and force the air, compress air, and all the washed these particles, or this will be washed out and evaporated out. So that is very important. Sterility will make a big difference in ultimate outcome. Don't try to save money on sterility. Actually, you will end up in spending more on your antibiotic, and much more on your reputation. One infection, one patient lands up with sepsis, and one patient lands up with increased stay, you will spend double time, double money on the antibiotic. And this, always keep in mind about the atypical mycobacteria, fungus. This is all going to come with persistent sinus, and I have seen large number of patients referred from different places. Why? PCNL was done properly, but there is a persistent sinus. Why persistent sinus? There is a fungus, there is a atypical mycobacteria because of side because of this. That is improper, not following the protocol. So common mistake, don't do it, because you will end up with lots of problems. There are many mistakes in energy sources, pneumatic, laser, suction. All this you have to understand which is useful, which is not useful, and what is useful in that particular case. No point in doing stag-on stone with laser. It is no pointless. You will keep on doing for 3 hours, still the phone will not be finished. Anesthesia, see what is you are comfortable with. Spinal GA, there are many patients, many urologists in conference. No, I do every case in spinal anesthesia. But if you are not comfortable, give general anesthesia. If you are comfortable with spinal, do it under spinal anesthesia. But you have to understand the technique in a particular spinal anesthesia, when patient is breathing, how to make puncture, how to do the nephroscopy, and this, once you get used to it, there is no problem. So make sure that what you are comfortable with, and then accordingly you do it. Coming to the technical aspects, while making puncture, a lot of mistakes which can be done. Spend time in planning. Very important that you need to plan your puncture. Decide which calyx you will take. Sometimes on RGP, you have done CT IVP, you have done NCCT, or you have done plain X-ray, or conventional IVP. Sometimes the RGP planning may change. So you have to see how is the system. Sometimes it may look to be spastic system, but on RGP it may be very well dilated. Even if you take multiple attempts to make puncture, it's okay. Wait till you get the best puncture. Don't just compromise. Just because you are getting puncture doesn't mean that everything is fine. Make sure that the puncture is the best puncture you get. And what is the best puncture? It is the shortest distance from the cup of the calyx. Majority stones can be removed from that puncture. It can be any calyx, not necessarily lower, not necessarily upper. Some people say, no, I will always go by upper calyx. Not right. Why should you go directly upper calyx? Assess case by case. Whichever calyx you think appropriate, do it. No, it can be any calyx, not necessarily prefix ideas. So some people will say posterior calyx, some people will say anterior calyx. So assess yourself and see. Now, this is some of the examples. Now, this is a puncture. Now you see that it is in the system, but instead of the going into the posterior calyx, it has gone into the branches which are anterior calyces. So you make a first time puncture, you get now nice good fluid. You inject contrast, it is going into the system, but this has no meaning, because from the anterior calyx what you have punctured to come from here into the this calyx and removing this stone will not be possible. So making puncture like this is of no use. You have to make a puncture in an appropriate calyx. So just don't compromise unnecessarily. Avoid central puncture. What is central puncture? Central puncture is the one which is not going from the tip of the calyx. Now, if you see, sometimes you make a puncture which you think is from the calyx, but moment you put a contrast, you realize that, oh, you have directly made a pelvic puncture or directly made a infundibular puncture. Now, even though urine is clear, everything is fine, don't accept it. Common mistake is to accept suboptimal puncture. Don't accept it. Remove it. You will make puncture again. There is no problem. You may spend more time. It may take 2 attempts, 3 attempts, 4 attempts. Doesn't matter. Just needle puncture has no morbidity. But accepting suboptimal puncture, you are going to land up with problem later on. Oblique puncture, avoid it. What is oblique puncture is that you are going through the infundibulum. You are not going from the tip of the calyx, from the papilla, but you are going from the tip. And as you see, there are many vessels which are running parallel to the calyx. They are all going to get punctured. Now, just needle puncture, nothing will happen. It's just a 18 gauge needle. It's okay. But moment you start dilating, there is going to be a tear of the vessel. These vessels will get torn, and then the bleeding will start. The bleeding will come here, and then you will be surprised and say, "Arey, what mistake I have done? My puncture was perfect. It was very clear. The contrast went into the system. Wire went into the ureter. No, but that was not a correct. It was not through the papilla. So that is a common mistake. Don't do that mistake. Quite often there is a zigzag track. This is a often mistake. You go inside, you think, oh, no, this is not a calyx I want to go. Withdraw a little bit and make a puncture into the calyx where there is a stone. Okay, now you have made it. So what has happened is that wire has gone properly, the puncture was proper, but moment you take out the needle, what is happening is that your track is zigzag. Your wire has become zigzag manner. Now this is a problem. There are multiple problems. When you are dilating, your wire may get kinked, and every time you have to change the position, you have to change it vertical, again make it horizontal, in which there is going to be a torque on the kidney parenchyma. And moment there is a torque, now from here you have to go into this for this stone, you have to bend the nephroscope here. You have to bend the implants, and moment you bend the implants here, that parenchyma will undergo a severe torque under traction, and that traction injury is going to cause severe bleeding. So your track has to be, therefore, when we define what is best puncture, is the one which is shortest distance, and it is a straight, not a zigzag. It is a straight track. So that is the best puncture. Okay. Now you see what has happened here. Whatever you saw in animation, you thought that, okay, this is a perfect puncture. But now see what is the problem which is facing, that this is the zigzag track. Track was proper, the calyx puncture was proper, but it was in a zigzag manner, and therefore now it is difficulty. You are facing difficulty in dilating. Whatever you are dilating, it is not going into the straight direction, and this problem is exaggerated because you are using glide wire. Glide wire doesn't have the strength. It will not become straight. If you use non-glide wire, it is PTFE guide wire, the guide wire is going to get kinked. And once the kink is there of the guide wire, there is no way you can remove the kink, then your puncture is wasted. So that is where the problem lies. So zigzag track has to be avoided. And this is a common mistake which people do it. And therefore, I want to highlight it. So this is another problem which of a zigzag track. Now here we saw that, okay, the puncture is made properly. Initially, it was here in the first case. Now we see what has happened is that this is what is happening. This is a zigzag track. Now this is the wire which is getting kinked. Now how to rectify it? It is a way to rectify. First of all, this should not happen. This is a mistake. It should not happen. Now what are the mistakes here? Very little guide wire. It is a zigzag track. The wire is getting kinked. This dilator is not going because it's a glide wire. Okay. So now how to rectify that? You need to have a rigid instrument. If you have rigid instrument, you can rectify that. This is how you rectify it. Remove that plastic dilator, remove that screw dilator, whatever. Now you put a Alkin's dilator or a rigid wire, and that will give the strength. And that is how you rectify it. And then change the wire if it is already kinked. And then make sure that it is the rest of the track dilatation is proper.
But
Now,
if you are
yeah.
having problem, better to do a repuncture also, na, sir.
Yes,
Remove it
correct.
and do another straight puncture.
Correct. So what generally we advise is that if you feel, see, sometimes what happens is that when you put a contrast, it is in the system, wire goes inside, but you know that in your mind that this is not a proper puncture, it is a zigzag tract, is that keep the wire
Okay.
and make another puncture, keeping the wire in place, because wire is a safety thing. In case if you want putting contrast or something, you can always do it.
Yeah.
Once you put a wire, now withdraw the needle, remove it, and make a next best puncture. And that puncture, once you know that, okay, now that is a good puncture, then remove previous wire and go ahead and dilate it. Another mistake is people are very, very hesitant to go supracostal. My advice is that don't make the mistake of approaching the upper calyx, which is a high calyx, especially on the left side, which is above the 11th rib, and you are approaching it subcostal just because you have a fear of puncturing the pleura. That's a big mistake. Pleural reflection comes to the 11th and 12th rib only on the medial side. So if your puncture is lateral, there is absolutely no problem. Pleura will never come into the picture. And therefore, supracostal, supra 12, never hesitate, but provided you are on the lateral side, posterior axillary line or lateral side. Only if your puncture is medial, and if you go supra 11, you may damage the pleura, but otherwise, there is no problem. Approaching upper calyx by a subcostal puncture, which is little higher calyx, then you are traversing lot of parenchyma. You are actually entering at the middle pole and then traveling all the parenchyma and making the upper calyx puncture because the stone is in the upper calyx. Now, in this process, there is so much of vessels and so much of parenchyma which is traversed by the dilators that you will end up in the more bleeding, and therefore your tract has to be straight as possible. Even though it is supracostal, it doesn't matter. So do not hesitate to make another puncture. I think that was a point you highlighted. It's
Yes,
very
sir.
important that don't hesitate to make another puncture. Common mistake is to remove everything, to do everything in one puncture. People are hesitant. No, I will bend here, I will bend there, but I will make sure that I will clear only in one puncture, which is not correct. If you think that the stone is not approachable, just make another puncture. You may use puncture wash technique, but you should not be worrying about another puncture. Now, this is what is the parietal torque. I think that that is what we saw it. And when you give excessive torque, now this is a place where you have made a puncture. Now you see the stone. There is a stone which is there. You have angulated it. There is an excess angulation. Somehow you have seen stone, but it is not coming. You still bend further. You still bend further. Now you want to see the stone. Actually, it is not seen. Your forceps is going inside that stone. You have caught the stone. You see on the X-ray that it is caught. Then you try to remove it. But in the process, moment you take out, this is what happens, that there is a severe gush of blood which comes in, is a frank blood. Why that frank blood has come? Because now in the process of bending from one calyx to other calyx, there is a severe bend on the infundibulum. And that infundibulum gets damaged, and moment you withdraw your implants from that, the traction is released, and then there is severe bleeding starts, which comes out as the frank blood from the ampla sheath.
Sir,
So
I want to ask two questions
yeah,
here.
yeah,
Uh, because it is a subjective thing, juniors somehow wants to chase it.
hmm,
Uh, uh, we feel sometimes that too much we are pushing the abdominal wall or the rib. And second question is so that we have to stop it. I
hmm,
mean, our hand and brain will be telling that you are using more. We should not
correct,
get tempted. That is one thing. That is
correct,
subjective.
correct,
Second,
correct,
somehow, if you take a smaller nephroscope, sometimes a little edge will come to take out the stone
correct.
with little water flow. Is it okay if you try once
Yeah,
gently,
yeah, yeah. So,
smaller scope?
so the tricks are that sometimes, as you rightly said, that it is a subjective feeling that you have to understand over a period of years that
Yeah,
how much is enough is enough. So that feeling you will get. And so you know that, okay, now this is not coming, okay, enough. Don't bend this too much. Now we make another puncture. That is one. Secondly, the bigger nephroscope will cause more torque. Smaller nephroscope will have a much more play while
Yeah.
doing nephroscopy, and therefore in a situation like this, if you think that there is a too much of a torque which is happening, change the bigger nephroscope to a smaller nephroscope, and then you will be entering the system and assessing the stone in a far better way. The third option is that sometimes you are there, only a part of the only 10% part of the stone is visualized, and you are not able to catch with the forceps. You are not able to break it with the lithoclast or whatever you are using it, because only the one tip of the stone is seen. The rest of the stone is not seen. There's too much of a bend which is happening. In that case, what you can do is that straight forceps may not be of a use. So what you do is that there are basket, Dornia basket forceps, nitinol forceps which are available, which are like a basket. So moment you press it outside, it will open up like a basket. Now they have they bent it the whichever way the calyx is going. You just open it so that basket will open, go into that direction of calyx, make a little bit rotatory movement, and in the process the swan will be caught into the basket, and then take it out. So these are the ways in which you can take out the stone which is stuck, or which is seen in the angulated calyx. Another mistake which is often seen is temptation of a particular procedure. Now, this particular procedure, it was thought that it's a very thick parenchyma, angulated stone. There's hardly any space. The all calyces are filled up with the stone, and therefore PCNL will be very difficult. There will not be any space. Moment you dilate, the stone is going to come into the picture. Moment you dilate further, the infundibulum is likely to get torn, and therefore it was thought that okay, now this let us do it in two stage of RIRS. And this is a common mistake. That is what is done. Even on RGP, you find that, okay, the calyces are absolutely undilated. So you do RIRS. But then you realize that these sort of stones are not for RIRS. These are our common mistakes which we tend to think and overstretch sometimes the indication of a particular surgery. It is interchangeable. Sometimes RIRS, sometimes mini PCNL. So it was an infective stone, slough-like material. Whatever you do RIRS, it is not going to get cleared up. And therefore, was realized that this is the mistake of doing RRS. So better to do PCNL and mini PCNL. Now mini PCNL, this was the puncture ultrasound guided. You see there is a calyceal puncture, proper peripheral puncture. Once you make a peripheral puncture, there should not be any problem. Mini PCNL, the big benefit is that you see everything, and we have a mini PCNL shock pulse, which is extremely powerful, and extremely powerful in not only breaking but also in sucking out whatever fragments are formed. So there's a slough-like, very soft gelatinous slough-like material. With the mini PCNL, everything is being sucked out, everything is cleared within no time. Whatever RRS you do, it would have been impossible to
Yeah.
finish that.
Sir,
So
one
this
more
is
thing, sir.
how,
One more, sorry to interrupt, sir.
yeah, go ahead. Go ahead.
Lot of people after doing 2, 3 cases only, they are taking more than 2 centimeter. Even those who come to workshop for us, they see and then to go attempt more than 2 centimeter and they do for 2 hours.
Hmm,
RARs.
correct,
I am feeling very commonly this is done. They will be seeing the stone and they will be continuing. Significant sepsis patients they call that 2, 3 days with the
yeah,
meropenem also fever is not coming down. What
correct.
do you recommend that, sir? Size of
No,
this
that's
stone?
why this is actually a common mistake that is being done, that you extend the indication unnecessarily to RIRS. Now, if your stone is bigger and
Yeah,
if you're going to take time, whatever, even though it is a straightforward stone, it is a big stone, there is no complexity, there are no awkward calyces, even though it is seen in but the time taken is too
yeah,
much,
yes, sir.
because time taken will be too much, and for that much time your intrarenal pressure, your temperature, your all these things going to be deciding factor about the sepsis, about the extravasation, about the fluid absorption, and all those things actually are not appropriate, and the
Yeah.
common thing, what we do is that we forget that for 2 hours, the
Yeah.
urethra was dilated with the access sheath, and that causes pressure necrosis. And therefore, there is a series of ureteric strictures which have been coming up because of the extended use of RIRS. So you have to understand.
Generally, if it is a stone is suitable for PCNL, you prefer from your heart more than 2 centimeter. You slightly you prefer to PCNL, sir.
Always mini PCNL.
Always mini
Always we
PCNL.
prefer mini PCNL.
And any stone procedure, you don't like to pull more than 1 hour. I mean, unless Tagore, that's a
Correct,
different.
correct.
Generally 1 hour may it should be finished.
If it is going to take that much time, or if even after 1 hour, if significant portion is still left out, it is better to stage the procedure.
Change the
So
procedure.
beauty of PCNL or any endourology procedure is stage. You
Yeah,
can always stage the procedure, no harm done. Wait for 24 hours, 48 hours, go ahead and do it. You are much, much safer.
safer.
Hardly any morbidity. So
Yes.
stage the procedure.
Okay.
All right. So identify the complications. Do not hesitate to stage the procedure. That's what we did it. Never make it a ego issue. Just because you have advised the patient that, okay, are nothing, I will do it. I can do everything in one stage. No, that's a ego issue. Ego will always land up with a problem. Now, many times this is what happens is that you take up something and you see puncture and you see there is a turbid urine, there is a pus. Now you have promised patient that everything will be done in one stage. Patient's count was okay. Patient was not symptomatic. In the past, there was history of fever and is that. And now you get frank pus. So there is always a dilemma whether to go ahead with the PCNL or you stage the procedure. Now it's a common mistake that you because everything was fine and there is a financial burden, there is a financial compulsion, and you go ahead and do it, and there you land up with problem because not only there is a pus, but these are a infection. Moment you start breaking the stone, when you dilate the tract, there are multiple blood channels, venous channels, they get opened up. And whatever infective material which is there, they are going to go into the systemic circulation. And that is likely to cause severe sepsis. And therefore, it is a common mistake that in a presence of frank pus, you go ahead and do PCNL. Better to put a tube. Wait for 24 hours, 48 hours, 3 days, doesn't matter. Once the urine is clear, you know that, okay, now everything is fine. By then, the antibiotics have acted. Now you are in a much, much better position than just going ahead with this. Another mistake, when you see the stone, when you break the stone, you see that suddenly there's a perforation. Now there's a perforation, and you realize that, array, this big fragment has actually gone outside into the perforation. Now you are worried. Array, everything is fine. Now this stone will be seen. No, no, no. I have to remove this stone because I have promised complete clearance. Now you go outside the system. Everything is fine. There is no bleeding. There is nothing. You see there is a perforation. Now you go and catch the stone outside the system through the perforation. And now in the process, you whatever that small perforation which was there, now that becomes bigger and bigger. And if that perforation extends into the across the PUJ, consider that his kidney is gone.
Yeah.
Any problem across the PUJ stricture is the stage further for the nephrectomy. And therefore, if you see the perforation, if it's a small perforation, some fragments have gone outside, stop the procedure, finish off rest of the thing, explain to the patient there are some fragments which will always be seen. Don't get mistaken, they are outside the system. Sometimes they go outside, but if you explain to the patient, they will always accept. And when they go to somebody else next time, they will tell, no, that doctor had told that there were stones which are outside. So that person also will be able to understand what exactly had gone wrong. So this is a common mistake. Don't do it again. Now, exit strategy, there is a thin line between confidence and overconfidence. And common mistake is not to understand what is confidence and what is overconfidence. If there is any trouble, which is you are expecting, no harm in putting nephrostomy. Don't make it an issue that, okay, no, I always do tubeless PCNL. No, I am a fan of tubeless PCNL. I am promoter of tubeless PCNL. No, case by case, where is the problem? It is not a defeat that you put a nephrostomy. It is all right. If you expect some problem, better to put nephrostomy rather than feeling sorry afterwards. Same is true for double gestant. Decide case by case. Post-op common mistakes. Proper careful monitoring is required. Prevent increased abdominal pressure. Many times you have seen like fantastic surgery done. Everything is fine. But patient at night had severe bout of cough or vomiting, or patient on while shifting had was shifted and suddenly there is a gross hematuria, clot retention, and everything has formed. So all these common mistakes should be avoided. Make sure that there is no constipation. If he is to be shifted from one ward to the other ward, it is shifted properly, especially in the immediate post-op period. Keep in mind all these complications. And if you keep in mind, you will not repeat the mistake. If there is a post-op hematuria, take the steps properly. It is important to identify the complication and take the steps. Complication, no problem. It is part and parcel of any surgery. Even though you have 40 years of experience, you can land up with complications. So it is not that complications are done only by junior, but the difference is that a senior person will identify complication, accept it and treat it. The junior person quite often will say, "Arey, nahi, nahi, ye to kuch nahi hoga. There is not going to be any problem." And then the complications are increased. There is a hemodynamic stability. That time you are running around has no meaning. By then the time has lost. So identify complication, act accordingly. Don't allow clot formation. If required, do ultrasound, do Doppler, do angio. Nothing wrong in it. If you think that there is a hemodynamic stability, there's a clot retention, there is a severe hematuria happening, there is a hemoglobin drop, no problem. Go ahead and do angiography immediately. Even if it is a negative angiography, it doesn't matter, but you have taken a step rather than delaying it. So also don't make a mistake of not advising the long term. Quite often you think that your job is over, the big stone, but always advise patient about the prevention of recurrence, metabolic workup, and general advice about the lifestyle, drinking water, and various other advices that you are going to tell them. Not advising thing is also a mistake. So these are all common mistakes which quite often we do it. We have done these mistakes, and therefore, I thought it is our responsibility to pass on these mistakes to junior so that they become wise, they become smart. We have become wise by our own mistakes, but I think they have to be smart, that they have to learn from our mistakes. It is our duty to tell that these are the mistakes which we have done, and therefore they should not repeat this mistake. Once again, thank you very much for this
Sir,
wonderful.
I will have quick fire questions because I had something in my mind.
Yeah, no problem.
Generally, very quick fire question, sir. Number one, if uh, all the cases of PCNL, if any rare blood group is there like O negative, if you are planning in a not district, if you are planning in a taluk and it's a larger stone, um, do you recommend that you take help of the senior, or you keep 2, 3 reserve, or you better not to do initial phases? These
So
are first 5 years people, sir.
yeah.
We are talking.
See, it all depends on your confidence level. If you think that you have done those sort of cases, then you go ahead, take all precautions, make sure that hemoglobin is proper, make sure that you have told the patient about properly, make sure that blood grouping is properly done. If you think that there is likelihood of complication, you can reserve the blood, but by and large nowadays it is not required. If it is happening in drop, you can always stage the procedure and all bleeding eventually will stop.
Keep the
If it happens post-op, then
keep
you have to have ready
early
blood.
stop if you have any problem, at least.
Yes, then you better that you reserve the blood, because sometimes if bleeding is severe in PCNL, what happens is that sometimes the bleeding is very severe. Suddenly there is a drop in the blood pressure, suddenly there is a hemoglobin drop, suddenly there is a clot retention, and you see on the whole kidney tray full of clots come in, because kidney is very vascular. There are 30% of your blood volume is circulated every minute. So within a short period, you get severe bleeding. And therefore, it is important that if you think that you are expecting problem, better to reserve, no harm.
Second question, sir. When you have done PCNL on post-op day 2, fecal matter has come from the nephrostomy site. This is discussed. This is not the forum we have to
Yeah,
go
yeah.
in detail. What I am asking is, uh, in which clinical conditions, usually it's a retroperitoneal. Usually it is retroperitoneal kidney, your dilatation, everything. Unlikely you have gone through transperitoneal. Uh, After doing the CT and confirming or whatever things, uh, how many times you feel that you have to open? Like we have seen 4 5 cases only in 20 years. We kept the opening wide and keep on waiting for 10th day, 15th day. It has come down in all the cases. Uh, how many times you have seen that immediately it has to be opened? Rare.
Very, very rare.
So
Hardly
message I
ever.
wanted to give to the audience is that don't hurriedly call the GA surgeon and open. Anna, sir.
Big mistake.
Big mistake.
If you see what you have described, that on second day, third day, there is a fecal matter which is coming up. Biggest mistake is to become panicky.
Panic.
Don't become panicky. This is a common problem. If it is on second day, if abdomen is soft, patient is taking diet and is that flatus is passing, there is no problem at all.
Yeah.
Most of these perforations are the retroperitoneal, and because there is a distal good passage, all perforations will heal
Healed.
by itself.
Yes.
Nothing, hardly ever we have explored the patient for
Yeah.
the
Even
for
I have.
the fecal perforation.
Third question, sir. Some people call me saying that, sir, today bleeding is happening, mild hematuria in the Foley's catheter. I have quick irrigation, no clots in the blood. For third day, again, some amount of hematuria. Usually, it should not happen. That irrigation is required in PCNL so much. We slightly say in the periphery, type 2, type 3, that try to have access immediately to the angio whenever necessary. Um they say that hemoglobin is 11, 12, sir, there is no problem. Can I continue? Sometimes fourth, fifth day when they cross. What do you say, sir?
See,
Hemoglobin
my advice to the people, a simple way, is that if there is not too much of a drastic fall in hemoglobin, there is no rapid fall in hemoglobin. If there is no clot retention, you have taken adequate care that there is an irrigation which is going on, and there is not too much of a tachycardia, there is a hemodynamic stability, there is no point in rushing unnecessarily.
is it?
But if there is any parameter which is not fitting into it, like for example, your BP has dropped anytime in the process, if BP has dropped and you have given a lot of fluids and other thing, and now BP has come up, hemoglobin has dropped significantly, 4, 5, 6 grams. If you have got, in spite of giving irrigation, there are some clots and you have to keep on giving washes and other thing, clots are getting formed, there's too much of a tachycardia, then better not to wait. Just go ahead and do angiography. Any peripheral center, my advice is that when you start PCNL in a large number, and you are expecting that you are going to do a lot of PCNLs, you must identify in your vicinity one center where they will be able to do angiography and if required, angioembolization.
Sir,
Nearby center, it cannot be in your own place. It's not
you
possible, but
friendly
any
center
nearby.
where they will listen to you,
Yes,
they will help you in the
yes,
patient in emergency,
correct,
and
correct, correct.
they don't bother spoil your name. They will
Yeah,
receive
correct.
that type of center.
Otherwise, when you said, "Arey, kya ho gaya? Arey, this has happened. Arey, this is a big problem,"
I
and
have
this
never
that.
seen like this, like that. Then he will be in trouble. More than
Correct.
angioembolization, the
Yeah,
entire this thing will go. Sir,
correct, correct.
in plural, this thing, sir, in all the MBBS days, final year, we used to put internship, small incision, mid axillary line, this seventh intercostal space,
Yeah,
we used to
ICD,
insert.
ICD.
In post-operative period, somehow anesthetist very rarely recognize on the table that I have problem in the pleura. They never tell.
Hmm.
We in the post-op patient says chest pain or some discomfort and we do ultrasound. 400, 500 ml of fluid if they say.
Yeah,
Should
yeah.
we put it directly chest tube or I mean honestly 400 ml I am giving why? Because it's Na idhar ka, na udhar ka. If it is
Yeah,
less,
correct.
it's okay. What do you say, sir? Generally, not in detail. Generally,
No,
did you
anesthetists will not recognize because they generally in a prone position, if you do it, they give positive pressure.
positive pressure?
Once you have positive pressure, then there is no, they will not recognize because it is going to go by force. So there is no problem in this. Only when they extubate, that is a time where the oxygen level may go down. And if they later on, if they complain, you find out if there is a significant fluid where is symptomatic, I think it is good idea to put a small chest tube. There is
Just
no
you.
harm. It is a
Benefit of
simple
doubt,
thing,
you
can
can
be
put.
done under local anesthesia. As you described, that is exactly what we do. And quite often, what happens is that this is quite often the blood in the pleural cavity. So it is good idea to drain the blood because even if it is going to get resolved, then the blood will cause a lot of fibrosis and the pleura will get thickened, pleura will get adherent to it. So
Sir,
it is better to drain that
to
thing.
drain
Is
it.
a simple small tube for 2 days is more than there's no hardly any morbidity.
Sir, one more thing. Big stone you have done, one more small stone, I mean small, 1 centimeter stone in the calyx. After removing the big stone, whenever you try to attempt the small stone puncture after removing, usually blood only will be coming. I mean, blood mixed, you cannot flush from below, and
Correct, correct,
you have to be really stone guided. Sometimes, if
correct.
you cannot do stone guided, you
Yeah,
feel that as if you are hitting the meat. You don't have that luxury in the beginning of
correct,
hitting a stone. Something
correct.
you need to be more accurate. In a peripheral center, junior, should you leave that if you have a problem, or see later on?
No, if it is a one simple stone which you think is not accessible, it is there, then it is better to finish it off, provided your previous one has gone quite well.
Previously got well
And
done.
as you said that you can't put contrast because it will go to extravasation.
Yes,
You
sir.
can't do anything. You can't distend the system because your previous track, everything is going to get extravasated. So it has to be stone guided puncture.
Yes,
Now,
sir.
if you're not going to get the feeling, then you have to rely completely on the 0 degree and 30 degree.
30 degree. Okay. Mhm.
Then, if you think that everything is fine, it is going, then what you do is that put a little bit of a saline and see whether the stone moves or not. If stone is mobile, it will move. Quite often, we judge only by the movement of the stone. The person who is doing of watching fluoroscopy, technician also will tell you, sir, movement ho gayi. So that means you are there. That is second thing. Third thing is that when you put a wire, see how it is coiling up.
Mm.
Now, if the your puncture is not inside the system, the way the wire will go is completely different than the way
Different.
the wire is going into the calyx. So these are the some of the methods where you can judge that you are in the system.
So you feel that if there are two, three punctures, better to puncture beginning, you also believe that, no?
Yeah,
Better to puncture
that
and
I
park
believe.
the guide wires.
Yeah, even if you are not going to use it, just take it out.
Just leave it,
But
and at the end you can take it
yeah,
out.
take it out.
Uh,
Better.
Sir, on the table, generally anesthetist will be sitting and you will be doing, we don't see at the bucket, little bit of bleeding will be coming along with hematuria.
Yeah.
This happens especially little once you become senior, you'll continue 1 hour and bucket, full bucket red color will come. What parameter on the table I mean, ideally surgeon should know that he is not doing well, but thoda stone, then your some bleeder major at the infundibulum will be oozing, but you have the vision. Uh, I had only once that patient has gone into stress syndrome in the young female. Many people say keep a watch on the pulse rate. So if the pulse rate is increasing more than 100, it is definitely alarming in GA. Do
Mm.
you recommend any other things you should be
No,
cautious?
so what you have to ensure is that your returning fluid has to be when you are actually doing what happens is that our eyes are on the monitor. We are going
Sir,
up, we are
yeah, yeah.
seeing, and the fluid is coming down, nobody is watching it. So what we do, our case, in our scenario, the residents has to keep a watch how the fluid is coming. Even nurses who are assisting, there is a sir bleeding RI. What happens is that common mistake, what happens is that when you are breaking the stone and your vision is very good because the fluid is going in.
Sir,
But if the implants sheet little bit comes out, part of it is little outside, then it is the tract which is bleeding. And that time the returning fluid is red. Your vision is clear, but the return fluid is red because part of the implants come out of the pelvic colorectal system. It is exposing the
Parenchyma.
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 And therefore, the nurses and this, they have to keep a watch that there is no bleeding coming in. If you think that this is what is happening, then you put the implants a little bit inside. Make sure that assistant holds the implants. It
Sir,
does not come out, and everything will be all right.
sir, sometimes I have seen 2, 3 times. Even for me, it happened thermoguide where you pass it and you wanted to take it out, it doesn't come out. And if you pull more, the outer strip comes out. And the needle removal is good part, I understand. But difficult puncture you have done, you don't feel like this thing. This is a problem. That may be manufacturer defect. If such material, which is the thermo guide wire and all, at the end of the surgery, is it worth tracing them and puncturing or leave it? Any other, of course, the metal foreign bodies you cannot leave it like that. Nowadays, this common problem is happening, sir. Yesterday also one person showed that amplast the RIRS tip while coming out because he has done a little tight ureter. The tip part 5 centimeter is retained in the ureter. It's very difficult to remove. For me, a triprong forceps tip has gone in a with my experience keeping in straight line, I have taken it out. Guide wire, if it coils and clearly seen on CM, outer coating will be seen so clearly, and patient lifelong can see it. Thoda, we feel that we puncture that area and do it, but that can bleed in the parenchyma.
No, if see, that is what happens is that suppose there is a foreign body like thing and which is not in the system,
You can leave it.
has gone out of the system, then it is very difficult to chase that because
Yes,
then
sir.
you will be nowhere. You will be
Yeah.
complicating bleeding and extravasation and everything will be all right. So even if it is seen, what generally we do in a situation like this, we have faced many times this problem.
Yes, sir.
Something has broken, something tip has gone outside, the wire has
Yes.
broken up, and this uncoiling of the previous PTFE wire was very common. You
Oh,
pull out the
that
wire,
green one.
an outer green thing comes out, and the inner thing gets dislodges. So what we do is that we put a contrast and see whether it is outside the system in 30 degree, 0 degree. If it is outside, we tell the patient that this is what is the broken thing. It is outside, no harm done. Everything will be fine, but it will remain like that. It is outside the system. Nothing is going to happen.
Okay.
If it is
Uh,
inside system, then you may have to, that time it may not be visible. But in the second stage, maybe after 48 hours, you again check everything. If it is in the system, then you can take it out. Because at that moment, because of clots and other things, you will not see anything.
yes, sir. Uh, Last two questions, sir. Densely impacted stone in a poorly functioning kidney. Two problems we see, sir. Suddenly, amplage comes out and we may not be able to go in because it collapses. Second thing is the stone becomes like a uh, 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 gum like it will be adherent to the mucosa. It won't break with pneumatic. Laser cannot be used. If you pluck out, there is a danger of plucking out. Uh, Especially upper ureter, mid ureter, densely impacted, poor functioning kidneys. This gum-like sticking out
Adherent.
because what to do, sir? Any trick in that?
No, if it is, this is very common in upper ureter. There's a densely impacted stone and it gets adherent. Actually,
Yeah,
if you pull the stone with the forceps, the whole mucosa also comes,
comes out,
gets
sir.
pulled up. So in that case, what we do is that we just leave it like that. You remove the whole stone,
And
whatever part which is adherent to the this, you just leave it. Very likely that
fall
this
off.
will
It
go
will
into
fall off
the,
over a period of time.
yeah, it will fall off. You keep a stent for longer period of time, maybe 1 year, 2 year. Make sure that the passage is widely open and this over a period of time, two things will happen. That whole calcification and other things will go away and the mucosa from urothelium will grow from the top and the bottom and everything will get healed, or else that will permanently form a stricture. If that forms a stricture, then you have to treat as a stricture, excise that segment and do end-to-end anastomosis or buccal or whatever you want to do it. But tell the patient that your mucosa was very adherent and even everything is fine. you will see there is some calcification in the wall. Somebody will report as a stone, recurrence of a stone. It is not a stone, it is adherent calcification of the wall.
Wall,
And
wall.
that has to
So
be
it
borne in
will,
mind.
so don't too much crazy about
Yeah.
plucking out everything.
No, no, no. It will then land up with
Stricture can form,
perforation and stricture.
hemorrhage and stricture. Last question, sir. Some people ask, sir, I started 3 months before. Obese patient is there, 110 kg, pelvic stone. Can I attempt the stone? Generally, we feel that obesity there is no much difference except the needle goes more deeper inside.
Correct.
One basic principles are same, and in fact, dilatation is easy, and then you can take it out. Uh, do you recommend if it is a easy case, obesity, there is no problem, you
Yeah,
can
no
do
problem. Only thing is that in obese patients, sometimes you need a longer instrument.
longer?
Because if obesity is too much, we have done in more than 55 BMI,
Sir.
and your skin to the kidney to skin distance is so high that your whole ampullars goes inside, but still you are not
Yeah.
in the system.
Last part will be hanging. Somebody has to
Yeah.
hold. Difficult. Some space.
So if your ampullage is just sufficient, then what you do is that for the ampullage, you put a towel clip, push it inside, so that ampullage should not get. Otherwise, you have to explore for
Yeah, for
removing
the
the ampullage.
you have to
That
give
is a
incision.
problem.
That's
And there are long ampullages which are available.
yes,
There
sir.
are long
Yes.
ampullages which are
Hook
available,
also available.
which you can buy and keep it. If you are getting the obese patient, then long ampullages is necessary.
Yes, sir. So I'll just see any important question. There are 7, 8 questions. 347 people like mini conference, sir. It is
Good, good, good. Very good.
347 is a mini conference, and not a mini conference, a regular conference.
Yeah.
Sometimes they're asking consent for RIRS to PCNL on the table. Better to take if you have doubt.
No, see, what we do is that any case of RIRS, every case of RIRS, we always tell that are you willing for PCNL in case if there is any tight ureter or not, or you want to stage it. So that consent we take as a part and parcel of every case of RIRS.
Yes,
So
sir.
it is better
So,
to do that. In case if you are not taken that and
yes, sir.
patient is under anesthesia, then you
Sir.
have to ask the relatives, or if you think that there is a problem, fussy patient, better to stage it.
Yeah, sir. Some upper calyceal stone, large stone. If you see above the 12th rib, if you don't know RIRS how to do it, somebody is asking, can we do a cross puncture from the lower to upper? From the below the 12th rib, you go up. Because
Yeah, but
if you are staying periphery, for example, senior surgeons in Hyderabad, some people they do always like that. They are very experienced. Though tract is long, they will confine to the lateral aspect of the Achilles in the
hmm,
entire tract. But
hmm.
still, any comment on that, sir? Because the question is
No, see, comment in that, okay, there are, as I said, that there are many people who have acquired the expertise in different way. There are hundreds of ways of doing PCNL in a very successful way. But for a general rule, or for by and large, the
short,
shortest tract is always better.
short tract is the better.
We tell our residents that don't hesitate to go above the 12th rib.
12th rib.
Absolutely no thinking at all. If you think that your tract is too oblique, better to go supra 12 and make puncture. But we don't go supra 11. There is a little bit of a risk which is coming up. And we have seen that most of the time, supra 12, everything can be
Can
removed.
be done.
Yeah.
And some people, in fact, go from above and then turn to pelvis. That is dangerous, no, sir.
That also is a problem because you go
Torque,
like this and then again like
then
that.
come down. That is not
That is causing a lot of torque,
taking the
and then,
kidney down.
yeah,
Sometimes
that is
kidney
a
may not
problem.
come down. That is a
That
problem.
is a problem.
So with this, it crossed 350. Everybody appreciated good discussion. Thank you very much, Sabnis sir.
Thank you.
We,
Thank
we
you.
always feel comfortable to talk to you, to share our feelings, and all pure urology viewers, especially the speakers and the teachers who have done 350 talks is not a small thing.
Yeah.
Some people say it's a reference that during the examination they are seeing the uh,
No, that is very good. So it's
uh,
a fantastic material.
yes, a
And
fantastic material.
these speakers that you have been calling are the experts, really
Experts.
experts in the field.
Yes,
And
sir.
therefore, what they are telling and what is the narration of their whole experience,
Yes, sir.
that you are giving ready-made available to the
Ready-made
viewers.
available
A
with.
very big thing, I must say, that contribution to the urology.
Thank you, sir. Thank you very much.
Okay,
With this,
thank
we
you.
conclude,
Thank
sir.
you.
Thank you very
I
much.